We're determined to keep on delivering CE opportunities here at Who Wants to Be an Eyecare Millionaire Intrepid Edition. I'm Dr. Carolyn Majcher, and I'm currently recording one of 5 additional educational sections, this one being focused on macular degeneration as well as geographic atrophy. So we can broadly subdivide macular degeneration into non-exudative and late-stage forms. Non-exudative forms we can then subdivide as being either early or intermediate stage macular degeneration. Early stage usually defined by a few medium-sized drusen, and then intermediate stage non-exudative macular degeneration can be characterized by a different number of things. So this could be one large-sized drusen, which is 125 microns in diameter. This is about the width of the caliber of a vein as it crosses the disc margin. So one large-sized drusen, or you could have extensive medium-sized drusen present, or any pigmentary abnormalities. So hypo or hyperpigmentary changes would also be classified as intermediate stage macular degeneration. And when we identify the intermediate stage, that's where we really want to start monitoring these patients more closely, seeing them more frequently, doing imaging intently to look for treatable forms of the disease, because we know they're at higher risk to progress to this late stage form. And late stage macular degeneration kind of comes in 2 different flavors. So we have neovascular exudative AMD, which we treat with anti-VEGF therapies. And then we have geographic atrophy. And typically when it's center involved, we would classify that as being late stage. There have been many risk factors identified for the development of macular degeneration, most of them being either genetic or non-modifiable. Unfortunately, age is actually the most important one, and then genotype being number 2. ARMS2 genetic mutations as well as complement factor H mutations have both been pretty closely implicated in the development of macular degeneration. And then with regards to lifestyle or systemic associations, heart disease, high blood pressure, obesity, certain dyslipidemias, dietary things, so patients that don't have a good intake of minerals, antioxidants, low omega-3 content are also potentially at risk. And the number 1 modifiable risk factor is so substantial is smoking. So patients who smoke, I think, have almost a 4 times greater risk of developing macular degeneration. They develop it early on, and they're more likely to have vision loss and blindness associated from macular degeneration. It's really interesting because even patients with 20/20 vision that have extrafoveal or non-center involved geographic atrophy are going to be symptomatic in some way. So decreased reading speed, they're having trouble keeping their place when they're reading, or especially poor vision in dim illumination settings. So you always go to that romantically lit restaurant and they're having trouble reading the menu to know what they need to order, and that can be embarrassing for patients. Patients with central geographic atrophy have these scotomas right in the center of their vision, and so when they're trying to even just walk down the street and somebody waves to them and they can't identify who that individual is, that can be something that's really embarrassing and frustrating for them, and a complaint that I often get from patients as well. So early detection of geographic atrophy is really important because the therapies that are available right now just slow down the progression of the disease. They don't halt it. So the earlier we make the diagnosis, the earlier we get treatment on board, the longer we can preserve functional vision. So we think about it, we're giving a patient a few more years of driving or a few more years of seeing their grandkids, and that can be incredibly valuable, and we can get more time if we start treatment early on. Yeah, some key tips for incorporating screening for macular degeneration and geographic atrophy into your practice. I think first and foremost is identifying patients who are at high risk of developing macular degeneration. So the older individuals that maybe have a family history of macular degeneration, or they have risk factors like cardiovascular disease, hypertension, obesity, smoking, screening these individuals closely, asking them about symptoms of macular degeneration and geographic atrophy. And then once we've identified those individuals, doing imaging. So I think the utility of multimodal imaging is absolutely critical in detecting early macular degeneration and geographic atrophy. So OCT, fundus autofluorescence, is going to be really important to have in your office or have available via referral in order to screen these patients appropriately. It's really important that we educate patients if they're having problems with their vision or difficulties to come in early. And this is especially important in geographic atrophy because once we lose vision, that process is permanent and irreversible. And geographic atrophy in and of itself is an irreversible progressive disease. So if they wait until they've already lost a lot of vision, at that point there's nothing that we can do, unfortunately. So the earlier we pick it up, the sooner they come into our office, the sooner we treat, the more vision we can preserve long term. So when we're looking for geographic atrophy, it's really important for us to incorporate like multimodal imaging modalities. And the two primary multimodal imaging modalities to look for geographic atrophy are going to be OCT, is really probably the #1 gold standard, and then fundus autofluorescence. But I also will utilize like near infrared reflectance imaging, in-fos OCT, in order to track progression of patients over time as well. I think there's some really interesting AI applications looking at the area of geographic atrophy, not only in just like the RPE loss, but also the photoreceptor loss. So I think what's going to be really exciting is we're going to be able to predict ways that geographic atrophy will expand based on AI applications utilizing OCT to say, oh, this is an area of photoreceptor loss, the GA is likely to expand in this location. And therefore, patients that have extensive photoreceptor loss are going to benefit most from these complement inhibition therapies because they're at greatest risk of progressing. So when we're thinking about just a general diagnosis of macular degeneration, it's important to first ensure that the patient's over the age of 50 and there are a presence of RPE abnormalities, whether that's pigmentary changes or drusen, really, these classic features to make that diagnosis initially. And then multimodal imaging is so important when we're saying, does a patient have geographic atrophy or not? OCT being the most important imaging modality for detecting geographic atrophy. And so on OCT technology, we're going to see damage of the photoreceptors, the RPE, and the choriocapillaris. So if we have an area of photoreceptor and RPE loss, that will typically create what we call a choroidal hypertransmission defect. So there will be light coming down through this vertical hyperreflective column into the choroid. And those are really important OCT features when we're trying to identify early geographic atrophy. What else is so beautiful about OCT technology is that we get really high resolution detail to even detect geographic atrophy before it forms. So these high risk OCT biomarkers for geographic atrophy development, which include reticular pseudodrusen or subretinal drusenoid deposits. It may be an area of ellipsoid zone photoreceptor loss, or what we call like subsidence of the outer plexiform layer. So you'll have some of the retinal layers kind of start to sink down as you lose the photoreceptors, and it creates like a V-shaped or a gull wing shaped configuration. And that's like an impending or nascent geographic atrophy lesion. Sometimes in these areas, we also get a pair of hyporeflective wedges that form on the border between normal retina and the impending geographic atrophy lesion. So these are all really important features to recognize. That is a patient that's likely going to go on and progress to geographic atrophy over time. Another really important imaging modality to make the diagnosis of geographic atrophy is FAF, or fundus autofluorescence, which essentially maps out the health or the metabolic activity of the RPE. So in areas of geographic atrophy on fundus autofluorescence imaging, The area of atrophy is going to be dark or hypoautofluorescent. It's going to have well-demarcated borders. And then in order to determine what the risk of progression is over time, we look at the junctional zone. So if we have a very bright hyperautofluorescent ring surrounding an area of geographic atrophy, that's sick RPE, that's likely to expand over time, versus patients that maybe don't have this ring of hyperautofluorescence are more likely to be stable or progress at a slower rate compared to those with a substantial amount of hyperautofluorescence. Once we've identified patients with macular degeneration, especially in that intermediate dry stage, we want to watch them more closely. So usually every 3 to 6 months would be my ballpark time frame for monitoring these patients in order to try to detect the earliest treatable form of the disease possible. So either neovascularization or geographic atrophy in this case. And the consistency of follow-up is so important because we want to detect the treatable formation as soon as possible so we can get treatment on board, right? So these treatments for geographic atrophy just slow the progression of the disease. So the earlier we start them, the more vision we can preserve. And if patients aren't coming in and they're not getting their imaging done, we're going to miss that conversion to the treatable form of the illness, unfortunately. Patient education is absolutely critical in ensuring follow-up compliance. And I love utilizing imagery to show this to patients. So if I have, especially images, say of geographic atrophy enlarging over time, of that particular patient's eye and saying, this is where we're headed and where we could be going even more down the line. So important that we're monitoring you closely, or so important that we're getting you referred to a retina specialist who can help slow down this process. I think when you show them an image and you show them progression, that really helps kind of put it into a realistic mentality for a patient. I think the #1 mistake that I see eye care providers do is refer geographic atrophy too late. So once a patient's visual acuity is already affected or they have center-involved geographic atrophy, unfortunately, there's nothing that we can do to bring that vision back. So early detection, early referral is absolutely critical for these patients. I will typically refer at the first sign of extrafoveal geographic atrophy. In the clinical trials that got these complement inhibition therapies FDA approved, typically it was 1 disc area in size. So, I typically won't wait for it to get that big before I refer a patient. It's kind of once I'm seeing it, I know it's likely to progress. And so by the time they get to the retina specialist, that could be a treatable lesion with regards to complement inhibition therapy. A lot of other factors that I consider in making that referral is based on my conversation with the patient. Are they willing to undergo intravitreal injections either every month or every other month? If no, then I don't see a point necessarily in referring, right? So I want to make sure they're on board with that. I also want to make sure they have realistic expectations with therapy, that we're not improving vision, right? We're not bringing any vision back. Making sure they understand that the vision is probably actually going to continue to get worse, just at a slower pace than it would have otherwise if we weren't doing complement inhibition therapy. It's really important for eye care providers not to rely on visual acuity when they're trying to say, should I refer to retina or is this disease progressing when it comes to geographic atrophy? Because you can have an area of expanding extrafoveal or non-centered geographic atrophy get huge and huge and huge, and it forms this ring around the fovea. The patient is somehow squeaking out 20/20 through that little island of vision when they could have benefited from complement inhibition therapy a long time ago. And so don't rely on visual acuity to determine if a patient's progressing or when you need to refer. Refer when the vision is still good so we can keep it good.